Okay.
Sí.
Okay, so it's 1:30. We can go ahead and get started. Not that many slides, so hoping that we'll be done well before 3:30 or 3:20 to be exact today. Welcome to those of you who came. Really appreciate your attendance. And we hope that, you being in class today can just improve your learning experience, and it'll be a nice little transition into the next topic series, which goes into heart failure. Heart failure is definitely, it's like one of my top favorite disease states to talk about. I love it.
It's pretty cool.
I love,
Yeah.
yes. I love
It's not cool to have it, right?
Not cool to have,
Right.
right. Not a fan of that whatsoever for our patients. But as far as talking about it, oh my God, it gets my blood circulating. It makes me feel like, oh my God. It's very pharmacy heavy. That's why I love it, because we as pharmacists, we play such an integral role in managing patients' heart failure. So yeah, I love cardio as a whole, but heart failure, it's like a different level of love. So
Anyway, I didn't know that about you.
Yeah.
That's great. I mean, I always enjoyed it, but that's great.
Yeah, definitely
Awesome.
one of my faves. So, and then there's a lot of research with how it's best managed for patients. We last had the clinical guidelines. They were last updated 2022. So, but there's still new and upcoming research. So we'll get into that and just talk a little bit about background. But as you can see, Dr. Culhane and I will be collabing for the lecture series tied to it. So it's going to be a nice combined effort. You can ask both science and clinical related questions in the same lecture, which is kind of nice. I hope that you all appreciate that. Compared to the previous series, it was more divided, but this time around it will be together. These are just some background reads, but essentially everything will go through with the lecture itself on what what the must know is for heart failure. So today is an intro lecture. This is more so to get you oriented to the series. As you can see, this is an all-inclusive objectives list. And this includes, identifying the different types of heart failure, compensatory mechanisms, Frank-Starling relationship, and how that relationship changes in heart failure, which will be highlighted through the science concepts. We'll go through the most common etiologies, modifiable and non-modifiable risk factors, some signs and symptoms that are consistent with heart failure, and then the lab and diagnostic test findings, and then severity as well. So as you can see, pharmacotherapy is not covered in this lecture because that deserves its own spotlight. So we're not going through any drug therapies today. This is just to get you, again, oriented to what the disease state is. So this just outlines what we'll go through further, go through the definitions, some epidemiology facts, pathophysiology, all the stuff that, is tied to the background. And then clinically how these patients present, the diagnosis, and then the different classifications of it. So definitions. Heart failure, to define it, it's essentially a progressive clinical syndrome, and it results from any structural or functional abnormality of the ventricular filling or ejection of blood. Those are the two main foundations or the reasons as for why heart failure takes place. Clinical syndrome, what that entails is there are symptoms that are tied to heart failure that the patient must have in order to be diagnosed with heart failure. And then in terms of how the impairments are classified, there's the ventricular filling impairment, and that's known as diastolic heart failure. And then ventricular ejection impairment, that's known as systolic heart failure. To give you a sense of which one we treat, It's usually the one that is the systolic heart failure. And systolic is typically tied to, again, based on looking at the LVEF, which is the left ventricular ejection fraction. This value, whenever it's less than 40%, aka like the very first row that you see here, heart failure with reduced ejection fraction, or we call it HFrEF, that is the subset that we treat pharmacologically. Okay, so that is considered the most severe kind. Severity, I guess, I don't know if that's the right term, but necessarily, like, we kind of just break it down based on which category of patients, like what their ejection fraction is. We group them according to that. So that's the subset that we treat. And then followed with that is our improved ejection fraction category. This means that at one point, the patient's ejection fraction was less than 40%. And now it has improved to above 40%. This is also a group of patients that we do treat because the treatment is what helped to improve their ejection impairment. So we want to continue whatever they were doing. Then we have the mildly reduced ejection fraction. Sometimes it's still referred to as mid-range. So this is somewhere in the middle where they're from 40 to 49%. And they have evidence of increased left ventricular filling. So this subset isn't always treated right away. And then same with the preserved ejection fraction category. This is above 50%. Yes?
When you say ejection fraction,
yes.
What do you mean? And secondly, when you say why is 40% our benchmark? Why are we not thinking of 50? Why are we not thinking of 60? Or why not 30?
Yeah. So to define left ventricular ejection fraction, so essentially how much of the blood is being ejected from the left ventricle, that is the marker that's considered like clinically significant. So that's a benchmark for basically as far as like outcomes go of the heart failure, how extreme those can be. And the lower that we get with that ejection fraction, the worse the outcomes are, as you can see. The particular mark of less than 40%, though, is what's based on evidence considered to be what is significant. You know, that's kind of how we group it.
Should we expect 100% in a perfectly healthy heart?
I've seen like high.
That would mean that the chamber is completely collapsed, which that's not possible. Like, it would mean that the chamber is completely squeezed out, which is not possible.
Yeah. So there's not exactly that scenario that would happen, but there's been times where there have been high ejection fractions that are noted in an echocardiogram, which is how we check. But essentially, the higher the percentages, we aren't jumping to treat them pharmacologically. It's like the approach isn't necessarily in that direction. The studies that I'll go through, some of the key trials that have been done are primarily focused on the reduced ejection fraction group.
If I can give you maybe some general numbers, just so you can visualize it, because that's always a really good question, right?
Yes.
When you talk about and this is on average, okay? And there's, as Dr. Manuel said, there's a lot of variability in this depending on how you're built physiologically. But when you look at the amount of blood that the left ventricle can hold when it's fully relaxed prior to contraction, it's around 120 milliliters of blood, okay? And, again, in an average person, again, depending on what the stroke volume looks like, it can eject like 70 mils every time it contracts, leaving about 50 mils left. So again, that's just an average general number. It can go up and down depending on the circumstances. Again, if a grizzly bear walks into the back of the room here, right, and our fight or flight response gets activated, okay, those numbers are going to change significantly due to an increase in cardiac contractility, okay, due to activation of the sympathetic nervous system. So yeah, and the ejection fraction, again, you can calculate that. It's just a percentage of blood that's ejected from the left ventricle as compared to what it starts with. So, 70 divided by 120, right, will give you the percentage, right? So 65, 70%.
5, 7.
Yes. Yeah. That's typically what normal echo that I've seen too. Somewhere around there is kind of where it'd be. But no, that's super helpful. Thank you.
Yeah, just because I always struggled with that too, just kind of visualizing exactly what are we looking
Yeah.
at, right?
Yes.
Yeah. So the treatment group for more than 50, is because of trials that have been done, and that's like the value, and it's because of that, because like evidence, you have maybe like landmark trials or meta-analysis studies say that less than 40 you have to like pharmacologically intervene.
Correct.
Okay.
So yes, and we mainly are concerned with mortality risk.
Oh.
So risk of death is higher as we decrease the ejection fraction percentage. When we talk about the reduced ejection fraction group, the risk of mortality due to really cardiovascular events increases, and that's why. Yeah. With that being said, I mean, there's more trials being done in this group in particular with preserved ejection fraction. So far, there's basically one class of medications that has been proven to have a mortality benefit, but there's not a whole lot of evidence in this subset. Our main evidence is in the first two rows, just to give you a sense of that. Any other questions? Good questions so far. Okay, and then this slide, more FYI, just to give you a sense of the magnitude of heart failure. So as you can see, the heart failure risk, it's 20 to 45% in Americans over the age of 45. In my practice, I see heart failure all the time. And that's why I get to do my job a lot. Like as a pharmacist, I'm heavily involved in working with those patients, making sure that they have a comfortable stay in the hospital, and then they transition smoothly out to be able to manage things outpatient. So yeah, very, very, very prevalent. And then incidence, you can see 1 million new cases that are diagnosed each year. It's the primary diagnosis in 800,000 hospitalizations annually, and the cost is outrageous. It continues to grow. We'll also talk about some of the cost barriers with some of the medications later in this series, but yeah, it's expensive to have heart failure. Black patients, male patients, they have the highest risk, and then white women, they have the lowest risk. This is what our demographic data suggests to us. And heart failure with reduced ejection fraction and preserved ejection fraction, they have about equal incidence, so it's about a 50-50 rate. Those with preserved ejection fraction, they're more likely to be elderly, female, and they have a history of hypertension. You may wonder whether these preserved ejection fraction folks can eventually get to a point of having reduced ejection fraction. It depends. Now, if it is caught at a point where they have preserved ejection fraction percentage, then if they take the right steps to ensure that they don't get to that point, then hopefully we can prevent it. But in the situation that things continue to go, in whatever way they're going, and the right actions and steps aren't taken, then it can worsen, because the nature of heart failure is progressive. So if it's not handled adequately in time, then things will progress onward for the worse. We'll go through the risk factors and causes. So when I say trying to control the things that are wrong at this time, hopefully that'll make more sense. I'm mainly referring to certain chronic diseases, lifestyle. Those are some things that patients ought to take control of. So that's what I mean by that. Okay, so we'll shift gears. We'll have Dr. Culhane walk us through the pathophysiology of heart failure, and then we'll go back.
All right, fantastic. Thank you. Okay, so with kind of building on what Dr. Naeem was talking about with us, we want to really kind of explore the different components of the causative factors of heart failure. Now, heart failure, if you have been paying attention here over the last 10 minutes or so, it's probably not a surprise to you to realize that this is a kind of a group of disorders, all having in common that the patients experience reduced cardiac output. That's the commonality. There's different types of heart failure, but the commonality between all of them is a reduction in cardiac output. So the heart isn't pumping as effectively as it normally would. We're going to talk about some of those reasons for that and why that happens. But again, I think what Dr. Naeem said, and we can't stress this enough, this is a chronic progressive disease. So once you have it, you'll always have it, and it will get worse over time, especially if it's not treated and managed well. As Dr. Naeem said, pharmacists play a huge role in that process because there's a lot of medications that we can use for that. Now, in terms of what causes heart failure, there are a lot of different causative factors. Okay, and the causative factor can determine the type of heart failure that you actually end up with. But one of the reasons why people end up with heart failure, it kind of ties into what we were just talking about before on the last exam with ischemic heart disease, is a myocardial infarction. So again, this is not the only cause of heart failure by any stretch of the imagination. A patient with long-standing, uncontrolled, or untreated hypertension that can lead to heart failure. There's a lot of other different things that different infections can lead to heart failure and things like that. But we'll start with this as kind of a baseline example of what can happen. Essentially, the thing that you want to always keep in mind is that the issue here is an increased cardiac output. So the pumping mechanism of the heart is impaired to some degree, and as well, the patient's ability to actually change and increase their cardiac output to meet different demands is also impaired. Okay, so there's Dr. Naeem's going to talk a lot about exercise intolerance and just and different struggles that patients experience depending on what stage of heart failure they're in and what kind of deficiencies they have. There are some compensatory mechanisms that the body will use, and we're going to go over here, okay, to try to, that's where I'm looking for, to try to not combat, but maybe combat or reverse the decline in cardiac output that the body's experiencing. So the body will use the sympathetic nervous system, the renin-angiotensin-aldosterone system, and increase the activity of these systems in order to help the body compensate for a reduction in cardiac output. So again, let's say, for example, I have myocardial infarction and I get some damage to my left ventricle and my cardiac output is impaired. We know that cardiac output, right, is a major component of mean arterial pressure, right? So as cardiac output declines, you can get a decline in mean arterial pressure, and that will lead to reflex activation of the sympathetic nervous system and the renin-angiotensin-aldosterone system. And those systems are activated to try to bring blood pressure up and cardiac output up. Okay, but the problem is, at least in the case I'm telling you about, is that part of my left ventricle is dead. Right? You can stimulate my heart with as much catecholamines as you want. It's not going to contract any more forcefully because I got a big chunk of my left ventricle that is dead. And once that heart muscle dies, it doesn't repair itself. Okay. In fact, if you're looking kind of futuristically, looking at some of the cutting edge science in this particular area, what scientists have been working on for the last decade or so is being able to develop therapies that will help heart muscle actually heal and repair itself. And that ultimately, I think, would be kind of a goal for certain heart failure patients. But the irony here is that the activation of these neurohormonal systems that attempt to bring cardiac output back up to normal levels, if they're turned on and turned up for long periods of time, that can actually cause further damage to the heart. So, again, in the short term, the body's trying to preserve cardiac output, mean arterial pressure, but in the long term, chronic exposure to epinephrine, norepinephrine, aldosterone, angiotensin II can actually cause structural changes in the heart that are not good, essentially, and that can worsen heart function. And we're going to get into that in a minute.
Dr.
Yep.
Cohen,
Yes.
Is this unique to cardiac muscle, or skeletal muscle would also be like no going back in terms of once the disruptor.
That's a good question. I'm pretty sure skeletal muscle can repair itself under those types of circumstances. It's just cardiac muscle that has that kind. They're almost like neurons. They don't necessarily. I mean, there are neurons that can regenerate and repair themselves in the brain. That's kind of a misnomer to think that they can't. But with cardiac muscle cells, from a genetic standpoint, they just don't repair themselves. And so, we're trying to understand why that happens, and why those cells are structured that way genetically and structurally. I think it's a big goal for researchers right now, because we can understand that the process that keeps them from regenerating, it's possible to turn that process off and allow them to regenerate. And so that's some exciting things that are happening in heart failure research. But good question. I think skeletal muscle can repair itself, yes. Yep. Yeah, so so I don't know if you can hear Kingsley or not, but there are, besides, a situation where you have a myocardial infarction and part of your heart muscle dies, you can get dilation of cardiac muscle tissue, you can get hypertrophy of the tissue. There's a lot of different changes to the cardiac muscle itself that can lead to heart failure, and those things are irreversible once they happen. So even though you might have a situation, and I'll show you a picture of dilated ventricle, okay, or a ventricle where the muscle walls are hypertrophied, very thick and fibrous and not very elastic. Those changes, when they occur, are irreversible. So just like damage and death to the cardiac muscle tissue, those types of changes, when they occur, can also lead to reduction in cardiac output, but are irreversible. Does that answer your question, Kingsley? Yeah. Okay. So let's take a look at the Frank-Starling relationship here. Now, I know that Dr. Joshi probably talked to you guys about the Frank-Starling relationship in biomedical sciences workshop, right? But we want to go over that again very quickly here today so that you understand it, because this relationship here is so important in understanding heart failure, okay? So let's take a look at the graph here. This is a very basic Frank-Starling curve. If you were to go into Google and type Frank-Starling curve and look at images, you'll see a gazillion different representations of Starling curves. But this one is very basic, and I like it because it just kind of shows you the basic components. So let's take a look at the axes here first so that you understand what we're talking about. Here on the x-axis, we have end-diastolic ventricular pressure, okay? So this is the pressure in the left ventricle when it is fully relaxed and fully filled with blood, okay? The other label that you could put on there that you'll often see, okay, is left ventricular end diastolic volume. So you can actually, if you have a pen, you can write that right beside pressure. You'll see some Starling curves that have that on the x-axis, okay? You will also see preload as another label that you can see on different Starling curves. They're all very closely related to one another and are often used as a kind of a measurement of how full or stretched the left ventricular muscle is. Okay, everybody got that? All right, now on the y-axis, we've got stroke volume. All right, if you remember, stroke volume is a major component of cardiac output, right? Cardiac output is equal to heart rate times stroke volume. And stroke volume is defined as the amount of blood ejected from the left ventricle every time it contracts or as it goes through systole, okay? And as I mentioned before, in the example that I gave, normal stroke volume, or an average stroke volume is about 70 milliliters of blood, okay? Everybody got that? So what this graph essentially shows, and the Frank-Starling relationship shows, is that as you increase the volume of blood in the left ventricle during diastole, okay, as that increases, what happens is the cardiac muscle tissue will get stretched, almost like a balloon gets stretched when you blow air into it, okay? And that stretching of the muscle actually causes a reflexive increase in how forcefully that muscle will contract during systole. So you can see here, okay, if we take a look at the black curve here, which is in a normal, okay, we'll take a look at the green curve, which is a normal curve, Starling curve. You can see that even a small change in end-diastolic volume or preload will cause a significant increase in stroke volume. So this is kind of a reflexive compensatory response that the heart uses to deal with increases in venous return and preload. Okay, so things don't get backed up. So if you get more blood coming back to the heart and preload increases, okay, your heart will respond by contracting more forcefully to handle that extra blood that it's dealing with. Everybody understand that? And you can see on the graph here, okay, that you can get significant in a normal heart, significant increases, okay, in stroke volume over a very small range of preload. Right? You don't need a whole lot of increase in preload in a normal healthy heart to get a significant increase in stroke volume. Okay. And again, assuming that everybody here has a healthy heart, nobody has heart failure, right? Your Frank Starling curve should look like this. And you can move on this curve, depending on what your level of activity is. Okay? So you're sitting there right now, right? Not a lot of physical activity going on, hopefully some mental activity going on, right? So your cardiac output and stroke volume is probably fairly low. You might be somewhere like right here on the curve, okay? But if I asked everybody to stand up and run up and down these stairs 10 times as fast as you can, right? Okay, what do you think is going to happen to your stroke volume? It's going to go up, right? And so you may end up somewhere up here at the top of your Starling curve, okay? So it's very dynamic. You can change the position. The position on your Starling curve can change depending on the level of activity, okay? Now, one of the things I wanted to point out to you here really quickly, and it's not shown distinctly on here, is that the difference between your resting, okay, cardiac output or stroke volume, okay, and your maximum is called your cardiac reserve. Okay, so again, the difference between resting cardiac output and maximum cardiac output is your cardiac reserve. Okay, that's how much of an increase you can get in your cardiac output to meet physical demands. Okay, and again, in a normal healthy person, there should be a healthy degree of cardiac reserve here. All right. Now, let's take a look at what a Starling curve looks like in a patient with heart failure, systolic heart failure. Okay? Just take a look at the red curve versus the green curve. Very, very different, right? If you look at the characteristics of this curve here, what do you notice as compared to the green curve? Just how, in terms of what it looks like. It's decreased, right? What's decreased? The maximum amount of stroke volume increase you get, right? What about the shape of the curve? It's flatter, right? It's much flatter, right? There's not nearly the cardiac reserve here, right? And in order to even get a little increase in stroke volume in a failing heart, you've got to have significant increases in preload, okay? Versus over here, if you go from here to here, that's just a little bit of an increase in preload. And boy, your stroke volume shoots way up in a normal heart. But if you take a look at here, in order to get that same increase, you've got to go from here all the way over to here. That's a lot of preload increase that you need to get in order to get a very small increase in stroke volume. Okay? So the Frank-Starling relationship is impaired in a failing heart. Okay? And again, what we can do here, you can see that this is a very different Starling curve. So you have someone who develops heart failure, right? Their Starling curve actually changes from this and change to this. And we can use medications, and this is what, again, what Dr. Naeem was talking about, to actually change this curve and get a patient on a new Starling curve. This black curve here. That's a patient with systolic heart failure, but is being treated with different types of drugs that we're going to talk about that can actually move them onto a new and better Starling curve. So you can see this curve here is a lot less flat, right? It looks a lot more like the green curve, right? There is a much better cardiac reserve there, okay? And the sensitivity of the heart to increases in preload is much better, meaning that, again, here, you don't need as much preload increase to get an increase in stroke volume, okay? Now, notice, no matter what we do, unfortunately, we'll never get our patient back to a normal, healthy Starling curve. We'll never get them back to this green curve here again. Our job is to take someone who's got this type of Starling curve and make it better, as better as we can. Does that make sense?
Okay, so that's what you meant when you say if it's already above 40, you probably will not get any medical benefits.
Yes.
Because I was thinking if I catch it early, I probably can take it back to its normal position. But probably when it's above 40, between 40 and 50, we don't get much benefit if you decide to do anything.
Yeah, and I think that, and I think that also goes to the point too, Kingsley, and again, we can talk about that more when we get to some of the medications, and Dr. Mayne can address that, I think, a little bit more. But it's, again, once that damage has occurred or that structural changes that can lead to heart failure that occur, we can improve heart function doing different things to a certain degree, but we'll never get it back to, we'll never reverse it, we never get it back to normal. Okay, does that make sense? So yeah, I think let's wait till we get to some of the drugs, and we're talking about some of the clinical stuff to really get into that. Okay, good question. All right, now let's talk about the neurohormonal pathways, compensatory pathways that I talked about 2 slides ago. Okay, so when we talk about heart failure over the next 3 or 4 days, we're going to be talking about managing and treating chronic heart failure, and there's a certain subset of drugs that we use to manage that and to prevent it from getting any worse. That's our goal, right? And then there are a certain subset of drugs that we use if we have an acute exacerbation of heart failure. We're dealing with a patient whose heart failure suddenly worsens and they need to be hospitalized, okay? And Dr. Gonzalez and I are going to talk about that next week. And again, there's some overlap between those 2 groups of drugs, but we're talking about treating a patient that's got heart failure, or we're treating them chronically and trying to maintain, heart function. What we're really doing here is we're using drugs to help to short circuit or inhibit this neurohormonal process that I have up here, shown up here, okay? And again, as I'm going through this process, I want you to start thinking about the different drugs that we've already talked about multiple times, and what kind of drugs we could use to short circuit this process. Because if this process that I'm about to explain to you is allowed to continue uncontrolled or unchecked, patient's heart function is going to get worse and worse and worse. Okay? But if we can stop this or eliminate it or reduce it, okay, we can preserve function for a longer period of time. Okay? So let's start. I want you to star this top thing here, we're at reduction in cardiac output. That's where we're going to start. So we have some type of cardiac issue that leads to a reduction in cardiac output. Okay. One of the common examples that I gave you on the previous slide was a myocardial infarction. It's not the only thing that can happen, but that's something that's easy to kind of envision, right? You have somebody who's got a myocardial infarction, maybe a blockage in one of their coronary arteries that feeds the left ventricle, and a segment of that left ventricle dies because it's not getting enough oxygenated blood. And so part of that muscle tissue is dead, and now the left ventricle can't contract as forcefully or as effectively as it once did. All right? What that does is that causes a reduction in cardiac output. Okay? Everybody, you got to understand that first before we can move on, right? If part of your left ventricle is dead, okay, if 40% of your left ventricle muscle is dead, what do you think that's going to do to stroke volume? It's going to decrease it, right? It's just that your 40% of that muscle tissue is dead. It's not going to be able to contract very forcefully, all right? And that, in turn, is going to reduce cardiac output, okay? Now, A reduction in cardiac output can lead to a reduction in mean arterial pressure. And we know that there are specialized receptors that are located throughout the body that monitor blood pressure on a minute-to-minute basis. And those are our baroreceptors, right? And again, I'm not going to test you on this, but just to review, there are major areas in the body that have high concentrations of baroreceptors. Your carotid sinuses, okay, monitoring blood flow to the brain. Your aortic arch, okay, monitoring cardiac output. And there are baroreceptors in your kidneys that monitor blood flow to your kidneys, okay? And anytime there's a decline in blood pressure, the baroreceptors, okay, will deactivate, and as a result, the sympathetic nervous system gets turned on, all right, in order to help bring blood pressure back up to normal levels. So we get SNS activation, okay? Another thing that can happen with regards to a reduction in blood pressure in the kidneys is that a fall in blood pressure can lead to the release of renin from the kidneys. And that's also can be stimulated by this SNS activation. So you've got two signals here that are causing the kidneys, the juxtaglomerular cells in the kidneys, to release renin into the bloodstream, okay? And that activates the RAS system, okay? We know that renin takes angiotensinogen, converts it to angiotensin 1, ACE converts it to angiotensin 2, right? Angiotensin 1 to angiotensin 2. And angiotensin 2 will stimulate aldosterone release from the kidneys, okay? So now we've got activation of the RAS system here. Do we have drugs that we know about that will inhibit the RAS system? All right? ACEs, ARBs, aldosterone antagonists, right? So this is what you need to be thinking about. These are going to be the types of drugs we're going to talk about that can be used to short circuit this particular system, okay? If you remember, and I don't know if we had time to get into this, but the sympathetic nervous system will stimulate renin release from the kidneys, from the JG cells, by activation of beta receptors, okay? Beta receptors, okay? So again, could we potentially use beta blockers to reduce renin release? Sure we could, okay? Now, as all of this is going on, the sympathetic nervous system is also causing peripheral vasoconstriction, which is also added onto by angiotensin 2 production. So we've got, a norepinephrine, we've got angiotensin 2 causing your peripheral arteries and arterioles to constrict. And that will lead to an increase in systemic vascular resistance or afterload. Okay? So if you're thinking about it, if you've got a damaged heart that's not pumping as effectively as it normally is, right? And you've got all these neurohormonal processes going on that ultimately increase afterload, you're making it harder for the heart to pump blood through the circulation in that way, right? So again, the increase in afterload here is, can be a problem. And so a lot of the drugs that we, use are used to reduce that vasoconstriction, reduce that systemic vascular resistance, reduce afterload, in order to make it easier for the heart, the failing heart, to pump blood through the circulation. Does that make sense? Okay, we've got ACEs, we've got ARBs, right? And so we've got drugs like labetalol or carvedilol that have alpha-1 blocking properties, right? So there's a lot of things we can do to alleviate the work that the heart has to do because of this increase in vasoconstriction, okay? Now, all of this stuff here, SNS activation, angiotensin 2 production, and aldosterone. If levels of these neurohormones remain high for long periods of time, and the heart is exposed to high levels of these hormones over a long period of time, what can happen is you can get cardiac remodeling that occurs, okay? So actual functional and structural changes in a heart muscle that are not good. They can only make heart failure worse, okay? So for example, a classic change that we see in the heart, in failing hearts, is hypertrophy and fibrosis. Hypertrophy meaning the enlargement of cardiac muscle, okay? And fibrosis is an increase in the fibrotic materials in the heart muscle itself that makes it less stretchy, right? More rigid and stiff, which is not good, okay? And again, catecholamines released by the sympathetic nervous system, norepinephrine, aldosterone, and angiotensin II, all of these things have been shown and demonstrated to cause hypertrophy over time and fibrosis, right? So again, if we don't want this to happen, what are we going to use drugs to do? Block the SNS, block aldosterone, and block angiotensin II. We want to prevent these maladaptive responses from occurring. Another thing, beta-1 receptor downregulation. Okay? I used heart failure as an example in Module 1 when we talked about receptor upregulation and downregulation. Okay? If you remember that, when cardiac muscle tissue is exposed to high levels of catecholamines like epinephrine and norepinephrine over a long period of time, and beta-1 receptors on heart tissue are overstimulated, okay, for a long period of time, the heart will respond by decreasing the number of beta-1 receptors on the surface of the cardiac muscle tissue and the nodal cells. Okay? That can cause, again, the heart to function less effectively and to be less sensitive to sympathetic stimulation. Okay? So that's a problem. Again, we can use beta blockers here, right, to shield these beta-1 receptors and prevent this from happening over time. Okay? And then cardiac muscle myocyte apoptosis. So these are big words here. Cardiac myocyte is simply a fancy word for cardiac muscle, okay, cells. A myocyte is a muscle cell, so a cardiac myocyte is a cardiac muscle cell. And then apoptosis, you guys probably talked about this last year in oncology. Apoptosis is a term that refers to programmed cell death, all right? So I like to think of it as sort of like cellular suicide, and cells will self-terminate under certain circumstances. And again, continuous exposure to high levels of catecholamines like epinephrine and norepinephrine over time can cause cardiac muscle cell death. And that only makes the situation worse. So all three of these things, okay, if they're allowed to happen, can make heart failure worse. So we've got a lot of drugs we can use to prevent this or limit it, and we're going to talk about those drugs, okay? Now, also, okay, the aldosterone, not only will it participate in cardiac remodeling processes, but it will cause the body to hold on to sodium and water. So you get a lot of sodium and water retention. And that coupled to the impairment in cardiac output can lead to issues with edema and things like that that we'll talk about more later on, okay? But with that increase in sodium and water retention, what we can get is an increase in preload, okay? Remember I said if you increase blood volume, right, that automatically increases venous return, right, and preload, so you get increases in preload. An increase in afterload, okay, or systemic vascular resistance can also increase cardiac preload, okay? If you have a weak, failing heart, right, that is having difficulty pumping blood into the aorta throughout the systemic arterial circulation, and we increase afterload and make it even more difficult, what will happen is the amount of blood that's left in the ventricle after it contracts is going to increase. Okay, and that will increase preload. All right. Now, this increase in preload, okay, can be a problem for us, but it can also stimulate the release of cardioprotective hormones from the cardiac tissue. Most people are pretty surprised when we talk about the heart as being an endocrine gland, okay, because it does have hormones that it makes and releases into the bloodstream. And these are natriuretic peptides. Okay. And we're going to talk more about drugs that mimic the effects of these natriuretic peptides, but these peptides are shown to be cardioprotective. So they can protect the heart from some of this stuff that's going on down here at the bottom, okay? And they can also reduce afterload, okay? As well as, having a diuretic effect as well, too. So these naturally occurring natriuretic peptides are actually very beneficial and can be released from the heart when preload starts to go up and it gets higher and higher. The problem is that the heart can't make enough of these natriuretic peptides to have a super therapeutic effect on here. So what we've been able to do is we've been able to create drugs that mimic the effects of these natriuretic peptides and kind of supplement what the heart's already producing and releasing. So we'll talk more about that. Okay, these can also serve as markers for heart failure as well, too, in terms of how serious the heart failure can be. Dr. Naeem's going to talk about that later on. Okay, so again, as we go through this here, okay, and as I go through all the drugs next week, we're going to keep coming back to this picture and fitting in the drugs in the different spots where they work. Because what we want to do is we'd like to turn this whole process off, okay? Or turn as many parts of this process off as possible so that we can limit or prevent this from occurring, okay? Because all this will do is will worsen heart failure and then give you further reductions in cardiac output, and this cycle just continues and gets worse and worse and worse and worse, all right? Make sense to everybody?
So the original trigger for all of this process is the reduction in cardiac output, so anything that would affect cardiac output will trigger this process?
Yes, and so again, chronically and over time, like we have moments where cardiac output will decline for a variety of reasons. In this case, the reduction in cardiac output is chronic, it's sustained due to either direct damage to cardiac muscle because of myocardial infarction or some type of infection or some type of structural changes that occur to the heart over time due to untreated hypertension or other types of things, and that can't be changed. Okay, I mean there are things you can change, like treating the hypertension, but once those structural changes occur in the heart, lead to that initial reduction in cardiac output, they can't be reversed. And then this process kicks in, and if it's not short-circuited or stopped or limited, this happens down here, the heart failure gets worse, and it just feeds back into this. You get a further reduction in cardiac output and more activation of these normal hormones. So it's kind of like a downward spiral that occurs. Does that make sense to everybody? Who's got questions? Because if you don't understand this, you don't get the drugs. Okay? It's impossible to understand why we use the drugs that we do. But if you do understand it, it makes total sense to me, at least. Who's got questions? We're good? All right. If you're at a point where you don't even know what question to ask, okay, please come and see me, all right? I get that. It takes a while to understand this. All right, so let's talk about some of these structural changes in Kingsley that we talked about before, so that you can kind of see what's going on. And again, these are some common types of structural changes that occur in the left ventricle per se. So if we take a look at this particular picture here on the left, we've got a cross-sectional picture of two hearts. One over here on the left is normal. Okay. Again, we've got the right atrium, right ventricle, the left atrium and left ventricle here. Again, you can remember from Biomedical Sciences Workshop, the left ventricle is the biggest chamber of the heart. It's also got the thickest muscle wall because it's the chamber of the heart that does the most work. Okay? All right? Now, if we go over here, okay, here we have a cartoon picture of the same heart with left ventricular hypertrophy. Okay? So, again, an enlargement of the muscle surrounding the left ventricle. And you can see that very clearly in this picture, right? Look how thick this muscle tissue has gotten, okay? And this is not necessarily a positive change here that occurs, all right? Because look what happens to the interior of the left ventricle here in terms of the amount of volume it can hold, right? As that muscle tissue gets thicker, okay, the amount of blood that the ventricle can hold when it's fully relaxed goes down. Not only that, but when that muscle tissue gets thick and fibrous like you see there, it has a very difficult time fully relaxing. All right? So in that particular situation, what we see is a reduction in end diastolic volume, the amount of blood in the left ventricle when it's fully relaxed. Okay? Does that make sense? okay? And the less blood the ventricle has in it before it contracts, the less it's able to eject into the blood, into the circulation, in the arterial circulation, right? Okay? Normally, like I said before, when your ventricle is fully relaxed, it can hold, on average, about 120 milliliters of blood. So imagine this over here, this left ventricle, when it's fully relaxed, it can hold 120 milliliters of blood. Imagine over here that this ventricle can only hold 60 milliliters of blood when it is fully relaxed, if it can even get fully relaxed. Okay? You see that? So there's less blood here to eject into the aorta than over there on the left. You follow me? Okay? And again, here's just another picture over here of, again, hypertrophic cardiomyopathy, similar thing that we're looking to over there, thickening of the left ventricular wall here. Okay? But I like that picture over there. I think it does a nice job of explaining what's going on. Okay? Here's another a picture of another type of structural change that can occur in the left ventricle that is also problematic. And this is a dilated ventricle. You can see over here, okay, we've got a normal, healthy heart here. You can see the ventricle muscle walls here, okay? They're nice and thick. But over here, the ventricle has become very dilated, so stretched out, okay? The muscle walls have gotten very thin, okay? Right? If you've ever had a pair of your favorite pajamas, okay? Pajama bottoms, the elastic band around the waist, right? And you wear them for years and years because you love them so much, and eventually that elastic band, it loses its stretchiness and it gets floppy, and you got to get a new pair of pajamas, right? That's what, when I think about this, I know it's ridiculous sounding, but when I think about this is what I kind of think about. That muscle wall's been stretched, it's dilated, it's floppy, it doesn't contract very well. Just like the elastic band in your pajama bottoms, right? It doesn't snap back and hold on to your waist like it did before because it's lost its elasticity. Okay? Again, you can see here, this ventricle is not going to contract very effectively. It's filled with a lot of blood because it's kind of stretched out, but its ability to eject that blood is very much impaired. Does that make sense to everybody? Okay? So the filling of the ventricle is important, how much blood can fill the ventricle. Okay, prior to contraction, that's important for determining stroke volume and cardiac output. But also, is equally important, is how forcefully that muscle can contract and eject blood. So there's a lot of things that will impact stroke volume, okay? And that will ultimately lead to a decline in cardiac output, okay?
Prof, in this second case,
Yeah.
there was an increase in the volume and a thinning of the wall that is happening.
Yeah.
I was just with the volume that is increasing.
I'm trying to hear the second part. Kim. I'm sorry.
Is it the wall is thin? Is it the thinning of the wall and the increase in volume, or just only the increase in volume of the ventricle?
No, it's both.
Both.
It's
so
both.
the wall thins out, so there's a kind of
The muscles get stretched out, it gets thinner, and there's just, there's a lot of volume in there that you just can't move it. Okay? Make sense? Okay? Dr. Naeem, I don't want to put you on the spot. Was there anything you wanted to add to this, or we're good? Okay, great. So this here slide, I think, is really important. And Phil, please feel free to jump in here because this has some significant clinical implications to it, okay? When, we talk about things like stroke volume, right? The amount of blood ejected from the left ventricle every time it contracts, and ejection fraction, right? Which is the percentage of blood, right, in the left ventricle that's ejected into the aorta every time it contracts. Those two numbers are related closely together, but they're not identical, okay? And I wanted to show you two different types of scenarios here so you can kind of get the sense that, again, when you're looking at just ejection fraction, it doesn't give you the whole picture, right, Dr. Naeem? You've got to be very careful about, you could have someone with a good ejection fraction, but poor cardiac output, okay? And this is how this works. So remember, ejection fraction up here, right, is, again, a percentage, all right? It's a percentage of the amount of blood that is ejected from the left ventricle as compared to how much blood was in the ventricle when it's fully relaxed. Okay, so for example, okay, and again, you could do the math quickly on your phone if you want to. End diastolic volume, right? The heart is fully relaxed and the left ventricle is full with about 120 milliliters of blood, right? When the heart, in that case, contracts, it ejects 70 milliliters of blood, leaving 50 left over in there, okay? So again, you take the amount of blood ejected, divided by the amount of blood that was in the heart initially, right? And you get a certain percentage, okay? That's the percentage of blood that's ejected. And again, we're talking about 70 out of 120, we're probably talking about 60 to 65%. I'm ballparking it there, you can do the actual numbers, but that would be the ejection fraction, okay? So let's take a look at these two scenarios, okay? So in scenario number one, we have a situation where we have a heart, failing heart, okay, that has good left ventricular filling. So the ventricle is able to relax fully, and it's able to fill up with blood effectively, and there's good end diastolic volume there, okay? But the muscle's been damaged, all right? So there's poor pump function. The muscle, just for whatever reason, maybe it was from a myocardial infarction, the muscle can't contract as forcefully as it normally does, okay? So again, if we start with an end diastolic volume of 100 milliliters of blood, which is pretty close to what I was telling you before, right? 120. This is 100. I think we did it just to keep the math simple, okay? And because the heart is damaged, its muscle is weak, we're only getting 30 milliliters of blood ejected every time the left ventricle contracts. So if we were to calculate ejection fraction here, okay, it's 30%. So in that particular scenario, the ejection fraction can tell us something very accurate about stroke volume in this scenario, okay? But it's not always the case, okay? Let's take a look at scenario number two, okay? Where we have, let's say we have, again, a heart where the left ventricular muscle is hypertrophied. It's very thick, it's fibrous, there's reduced ventricular space for blood to fill into, right? Okay? And so we have poor filling there. That ventricle can't relax. There's not a lot of space for blood to come in there, okay? But there's decent pump function. That muscle can still constrict pretty well. There's still a good deal of contractility, okay? And let's run some numbers. This is, again, an example of diastolic dysfunction, okay? So let's say in this case, because of the structural changes that have occurred in the heart over time, it can only fill with 50 mils of blood. That's it. That's end diastolic volume there. That's half of what we saw in example one, right?
Yeah.
Right? It's just a little bit of blood. But this heart, okay, the muscle can still contract pretty forcefully. So when it ejects blood, it'll eject 30 mils. Okay? In that case, the ejection fraction, if you calculate it, is 60%, which would seem really good, right? But look at the amount of blood that's being ejected into the aorta. Only 30 mils. How much in an average person should be ejected? 70. Yeah, right? So again, all this is telling you is that ejection fraction can be misleading, right, Dr. Naeem? And you have to have more information. Just because someone has good ejection fraction doesn't mean that their heart is effectively pumping blood throughout the circulation. Okay? Does that make sense to everybody? So if you're looking at ejection fraction, you got to know what's going on, right? Okay. Any questions about this?
Okay. So this has to do with, does that mean something? What's going through my mind?
Yeah.
That the stroke volume is body mass and size.
Yeah.
Can also play a role here, because for somebody that is very large, the large body mass, the volume, stroke volume might be 60 and it's a problem, whereas for a smaller person, stroke volume might be 30 or 40 and it's fine.
Well, that's an interesting question. Do you ever see variability like that, like very, very large patients versus very small patients?
Weight can play a role just as far as we usually track it in terms of more like fluid status, but not at baseline. So like not necessarily when it comes to thinking about this aspect, but more so when it comes to actually managing those patients with treatment, which is basically trying to regulate their fluid status. So that's where like the weight is a factor that would matter. But it's not evaluated on a level where we're trying to like basically look at the difference as far as stroke volume or, ejection fraction, how that plays a role, if that makes sense.
So I mean, so Kingsley, what you're trying to say, Carl, I'm going to pick on you, and I don't mean to pick on you, okay? But Carl and I are very different, right? In terms of our size and our weight. Carl is very tiny. I'm a bigger guy, right? So what we're saying here is, let's say you had a stroke volume of 30 mils, and I had a stroke volume of 30 mils. Would there be any? Would Carla be able to function better with that level of stroke volume versus me, because I've got a lot more tissue mass to circulate blood through? I mean, it's a good question.
Mm-hmm.
I don't think, like you said, we don't really, it's not something we really consider clinically when we're looking at these numbers. Stroke volume is stroke volume.
Right, exactly.
You got it? But it's an interesting question. And I don't know for sure, physiologically speaking, but Carla, thanks for your participation there. I appreciate that. But at any rate, any other questions about this? If you're confused or this is like blowing your mind, right, the best advice I have for you is just take about 10 or 15 minutes and work through some of the numbers a little bit, okay? Look at the math again. All right, what are the numbers telling you, all right? And if you're confused, it's probably because, again, you have to understand what end diastolic volume is, right, versus stroke volume, okay? And how do we calculate ejection fraction? That's really important to understand that. And running through the numbers. But we have two scenarios here. In each of these hearts, the stroke volume is the same, the amount of blood ejected from the left ventricle every time it contracts. However, the ejection fractions are very, very different because we're starting with different amounts of blood. Yes?
One more question.
Yeah.
If I go back to the first slide of definitions, we talked about heart failure with reduced stroke EF's ejection fraction less than 40%. So if I superimpose this now with the case that we have done, we probably might not classify, I don't know if I'm correct, the second patient who had a stroke who had an EF of 60% may not be classified as having a heart failure if we were to use this classification. Would I be correct?
In the preserved ejection fraction category, that's where they would fall.
Right down near the last one.
Mm-hmm. Yeah.
So even though they had good ejection fraction, Kingsley, they probably still have like the symptoms of heart failure, right, Dr. Naeem?
Yes.
Shortness of breath, they might have peripheral edema. We know that they have heart failure, and when we go to measure their ejection fraction, it seems preserved. I mean, it's a high number.
Yeah.
Exactly.
But it's still, but again, the heart's still not pumping blood as much blood as it needs to.
Right.
Does that make sense?
Okay, so for our classification, we'll classify them under what number?
Right. So if we go back here, let's go back here. The HFrEF and HFpEF, right?
Yeah.
So again, right here,
This would be in class.
this is HFrEF right up here, the first one, right, Dr. Naeem?
Mm-hmm.
No,
Right.
first one, yes. That's
Right.
HFrEF there. Mm-hmm.
Okay, so number 2 will now be category
HF.
D, class D, which is
Preserved.
Yeah.
Oh, okay.
Yes.
You got it?
Yes.
Okay.
I got it.
And we'll get more into that later on, correct?
Mm-hmm.
Okay.
Yep. A lot more of it.
A lot more. All right, hold on one second. Let me get back. Oh, wait a minute. Yeah, so we're done here. And so any more questions about this? I'm going to turn it over to Dr. Naeem, and we're going to probably forsake the break.
Yeah.
Anything.
Yeah.
If
That's
you want
perfect.
to, and we can just get done. Is everybody excited about that? If you need to go use the restroom, please feel free to go. Okay? All right, but we're getting close, and
Yeah.
Dr. Naeem is much more concise and brief than I am. But again, if you understand the neurohormonal stuff, that's super important right now. So focus on that if you're going to focus on anything this weekend.
Okay, so shifting gears back to more of just like the patient perspective, thinking about clinical things. So we look into etiologies of heart failure, and just to redefine etiology, it's essentially looking at the causes, what led to the onset of heart failure, some of which may be reversible. So same concept as like what we've looked at for modifiable and non-modifiable factors over other disease states before this. We look for the signs and symptoms and then exacerbating factors, things that make the heart failure worse. We also factor in some lab tests and imaging to look for structural, functional abnormalities. And then severity-wise, so you all, you saw the table that breaks it down in terms of ejection fraction, but we do have further classifications on looking at the severity based on symptoms, and then also just like staging based on what extent of structural disease we have. So we'll get into all of that. So as far as etiologies go, the most common underlying conditions that lead to the onset of heart failure are hypertension and coronary artery disease. And the nice thing is that you all are experts on that by now, right? Because we covered that across exam 1 and across exam 2. So those things you are familiar with, you understand kind of what the background of each is. And it's a nice segue into now what we're covering, which is heart failure. So those are the ones that I would say you should keep in mind for sure. These other ones are obviously listed as also being associated with leading to heart failure, but I see the top 2 as the most common reasons. Like if patients come in with heart failure, chances are that it's very likely that they had underlying hypertension that was long-standing, uncontrolled, not managed adequately, and they needed to optimize treatment for it. And if they didn't, then unfortunately it led to the development of heart failure. And that's what I was saying before with trying to, like if, say a patient does have preserved ejection fraction and they have a diagnosis for hypertension, you want to ensure that the patient is adequately managing their hypertension to avoid that ejection fraction to drop further to that below 40% range. Yes?
Patients that are naturally hypotensive, I'm sure they also come down with issues of cardiac fraction.
Yes.
So in that case, would they follow that genetics or what would that be?
Yeah, so if someone is hypertensive and hypotensive, gotcha. So if that's the case, I mean, lower blood pressure doesn't necessarily predispose patients in this case. It's more so high blood pressure where we run into that concern, which hopefully makes sense given some of the background that Dr. Colleen covered, just with like the physiology of the heart. There's like stroke volume, cardiac output, those things that are involved. Hypertension, as you all know, it's essentially like there's a pressure in the vasculature. So like there's a buildup of that which affects, how much constriction there is in the arteries, which affects how blood is able to flow smoothly. So the more constriction there is, the more hypertensive a patient essentially is, right? And that constriction is what's bad. In hypotension, we don't have that same concern, right? Like there's rather more of like the dilatory effect. But either way, hypertension would be more of a problem for us.
And if you think about like we showed you before, the hypertrophy, so the heart where the ventricle is hypertrophied, again, that's something that can happen when in patients with hypertension that's not controlled well or that has been undiagnosed, right? That ventricle is going to work really hard for maybe months or years and years over time. And what will happen is the adaptive response the heart will go through is to increase the thickness of that cardiac muscle, but it's not a good adaptation because that muscle gets very thick, the ventricular space gets small, and that ventricle muscle has a difficult time relaxing. So that in that case, the hypertension can cause structural changes that lead to a reduction in cardiac output. Does that make sense?
So technically, patients who are hypotensive, because I see some patients whose blood pressures are something like 90, 60, 90, 50, and you're trying to push the blood pressure up, they can never have this disease?
That's never say never. So that's never say that.
Do you find some of those kind of patients in the
It
clinic?
can happen, absolutely can, because of something else that is listed here, or, other etiologies. Yes, but blood pressure wouldn't likely be the cause.
Okay.
Yeah. But as far as prevalence goes, hypertension, like I would say at least 90%, 80 to 90% of patients that I see, if they have heart failure, they have hypertension. That's likely where it started. Yeah. Any other questions? There's some good points. Cool. And then as far as risk factors go, so tied to that, we have some modifiable things that the patient can hopefully get under control, which can ideally prevent the progression of heart failure, that being getting their blood pressure under control, coronary artery disease, as we've covered, that involves different forms of therapy like statin therapy, dual antiplatelet therapy, depending on if they have, if they have stable ischemic heart disease, or plaque stabilizing agents come into play there. And then our beta blocker, calcium channel blocker, those are kind of where those things would come into play. And then these are some lifestyle things, so like tobacco use, alcohol intake. Same rule with diabetes as is hypertension, as in trying to ensure that the patient gets their chronic disease under control. And then the things that are non-modifiable, hopefully you all understand, can't change anything about patient's age, their race, gender, genetics. Those are some things that are kind of, they are standing, and it's kind of what the patient has to deal with. But that's, usually how we break those down. So as far as symptoms go, the main things that we are concerned with in heart failure patients. So there's the dyspnea, which is difficult labored breathing, having a hard time to breathe. Okay, this is a question on the exam yesterday. Ticagrelor was the answer, by the way. That is the P2Y12 inhibitor that can cause difficult labored breathing. But anyway, just thought of that term, and I was like, I remember some people asking that question. So difficult labored breathing, to define that. And then fatigue. So these are some extremely common side effects, or rather symptoms, I should say, symptoms of heart failure. And this is all tied to a dysregulation with fluid status. So having fluid overload leads to these symptoms. And then this in turn can also lead to exercise intolerance, as you can imagine. So anytime a patient is physically working out, then they are gonna, clearly it's gonna make things worse for them because they're gonna have a hard time. There's also orthopnea, which is a common symptom. So this is the difficulty in breathing, having labored breathing when a patient is reclined. So in order to alleviate this, you will note that patients use a lot of pillows to prop their head up so that the fluid doesn't get to them and doesn't affect their breathing. So at night, usually one of the common questions that we ask these patients is, how many pillows are you using to sleep at night? And I usually get a ballpark answer of about 4 to 6, which is crazy. Like, imagine having 4 to 6 pillows under your head to sleep, just so that you don't, the fluid doesn't get to your lungs and affect, make you short of breath and all that. So crazy. And then there's also paroxysmal nocturnal dyspnea, PND. Again, something that is like an inconsistent level of like having difficulty breathing throughout the night. And then early satiety, anorexia, these are some things, because these patients, because of their fluid status, it just affects how full they feel, how much they're willing to consume, how much they're willing to drink also. So it's just, the fluid status plays a role in everything here. And then signs of heart failure. So this is looking at just on physical exam. So when we evaluate these patients, there's pulmonary congestion that's noted. So just fluid buildup in the lungs. And so when they're examined physically, there's these like rail sort of sounds when they're breathing, like when they inhale and exhale, sounds like, sort of this like rattling sort of sound. Pulmonary edema, again, edema refers to the fluid buildup. There's this S3 gallop sound, palpitations, heart murmurs. Again, this is done typically by our, physicians, and they kind of look for these things when they do a physical exam. And then jugular vein distension, so that's essentially looking at the vein that's right here on the neck, and it usually it bulges out. It looks very prominent. There's also hepatojugular reflux, so this is when on physical exam, the evaluating figure, they put pressure on the abdomen, and that makes their jugular vein distension increase, makes it bulge out even more. Hepatomegaly, that's just enlargement of the liver. Ascites, which is this fluid retention that patients may have in their abdominal cavity. So you can see they're up your belly essentially. Peripheral edema, you can see fluid buildup in the extremities, the arms and the legs. And then the weight gain. So this is what I was saying earlier. We look at how patients are, what their baseline weight is. And then when they're in a state of heart failure, if they're symptomatic, then we look to see how much of an increase they have in terms of their weight. Again, all tied to their fluid status being out of order. And then they can be hypotensive sometimes. Now, if that's the case, typically that raises concern for more of a decompensated state, which I won't get into today. Well, that's more to come with that, but sometimes that can be seen, so that's why it's here. Any questions about these? So for your purposes as a pharmacist, when you think about these things, some of these, I'll be honest, I'm not involved in identifying these things or being well, the patient has an S3 gallop, because I don't do physical exams, and pharmacists typically, they keep track of that, and they essentially look out for these signs and symptoms, but it's not necessarily something that we do in our practice. But I will say, when collaborating with the team, we hear these terms, you can say, oh yeah, that's consistent with heart failure. So that's the point of this slide and the point of me highlighting these things to you. All right, as far as diagnosis goes, it's a combination of different things. So we have a clinical diagnosis based on history and physical exam. So the things that we just covered, usually it's suspected due to presence of symptoms that are consistent with heart failure. And again, all the symptoms, they go back to fluid status. When there's an irregularity with that, that's what causes the fatigue, that's what causes the difficult labored breathing, those sorts of things, the pillows, having to use an excessive amount of pillows. If we have suspicion for heart failure, then we go on to do some lab tests. That includes a complete blood count, electrolytes, we look at renal function tests, which is serum creatinine, BUN, A1C, lipid testing, liver function tests, so the full 9 yards, as you can see. A lot of things. The ones that I have underlined here, the BNP, NT, proBNP, we typically look at how this is abnormal, and any abnormal finding with that is consistent with heart failure. So these other things are kind of thrown into the mix, but the one that primarily stands out to us would be the BNP, NT-proBNP, which I'll get to. And then as far as imaging goes, so these other tests may be done. EKG is done in the case of suspected any sort of arrhythmia, so any sort of rhythm disorder. Chest x-ray, it's typically done if we have suspicion for could it be heart failure? Could it be some sort of chest infection? There are abnormal findings typically on a chest x-ray to indicate that. So that's why that diagnostic test is done. But the echocardiogram, that is our key gold standard hallmark that we do to determine the patient's ejection fraction, any sort of structural abnormality, anything that's going on in terms of that. The echo, which is what is commonly referred to as, helps for us to identify that. Question?
Yes. When I looked at the symptoms, the first thing that came to my mind was, why is this patient not having COPD? I know we have to look at, you know what I mean? So it looks like they become clouded by COPD. So what is that diagnostic how do we come to the conclusion that this patient actually has heart failure? Because the signs and symptoms could be masking some other kind of resistance.
Yeah, great
What
point.
do you make?
Yeah, so, sorry, I don't mean to cut you off. Go on.
So find out, this was that unique identifier for us. That okay, if I see a question in the exam, I'm thinking of a big exam now, which is not focused on this. And then I
Yeah.
see the question. I don't know whether the question is coming from COPD, whether the question is coming from heart failure. What should I look out for that tells me that this is clearly heart failure case and not the COPD case?
Yeah. So what you're basically highlighting is what we call differential diagnoses, which is basically like, these are the things that we're noting with the patient. Let's come up with a list with what could possibly be wrong. So one of those could totally be COPD, asthma, and one of the ones that I just pointed out with the chest x-ray, we would do, we could have suspicion for an infection, like pneumonia, right? So that comes up all the time, just to give you a sense of that. Like, we don't have a clear picture always, and it's like, it could be this, it could be this, it could be this. So that's where we look for as many things that are in alignment with heart failure. So the symptoms, they can be a little non-specific, right? But if we have suspicion for, say, COPD, right, we would look at, again, the specifics for that, the risk factors. We would also consider, like, well, that's where, like, our lab tests and our imaging, that's where they play a pivotal role. Because as we do these things, then they would help to rule out or narrow down what could possibly be up. So as I mentioned, our echo, if we conduct an echo and we see abnormal findings there, then chances are we probably have a heart failure case. It could very much be possible that there's patients with multiple comorbidities. So sometimes there is a case where heart failure and COPD are both concurrently happening to the patient, and sometimes it could be both exacerbations, which is awful. Like, I've seen that before, very complex. They have an exacerbation in their lung disorder, and then they also have this heart failure situation going on. But I'm not going to speak to COPD because that's a different path of, like, kind of what they work through to diagnose it, identify that that's the problem. But for heart failure, just speaking to that, I would say, like, at bottom line, our echo is typically what it would be. Plus, like, you know, if we are also seeing signs and symptoms that are consistent with that echo finding, then we probably have a heart failure case.
Can I add something in real quick?
Of course,
Because I think, with this slide and the last one, as Dr. Naeem said, some of the signs and symptoms, the signs of heart failure here, you're talking about peripheral edema, weight gain, fluid retention, right? If we go to the next slide and we look at the natriuretic peptides, the BNP, NT-proBNP, remember, those are peptide hormones that are released from the chambers of the heart when preload is very high. So as preload increases and that heart muscle is stretched like a balloon, that stimulates the release of these natriuretic peptides into the bloodstream. So the more preload that you have, when it starts to get abnormally high, you're going to see higher and higher levels of your natriuretic peptides in the blood. That's why that's such an important marker for heart failure. I don't think I covered that when we talked about that. I just talked about its cardioprotective effect, and then it's released from the heart. But the stimulus for the heart to release that is stretching of the ventricle wall. There's a that's a mechanical signal that stimulates the release of these natriuretic peptides. The more stretch, the greater the preload, the more peptides that you'll find in the blood, natriuretic peptides. Okay?
Any other questions? Awesome. Okay, so getting right into it.
I forgot we had this come out here. I'm sorry.
Yeah. No. This is perfect. Yeah. So as Dr. Cohen already gave us some background, so this is generated by cardiac myocytes due to myocardial stretch. And so this estimates, how severe the heart failure is, and it increases when the patient is fluid overloaded. So again, as highlighted, this would really help to differentiate our underlying heart failure compared to any other abnormality. So BNP, if we see a value of above 100 or an NT-proBNP of above 300, then those indicate fluid overload. Those indicate basically some level of like injury or some level of like, excess fluid buildup. And so that's kind of where our markers, like if they're in that range, we would make note of that. So they are supplementary in helping to make the diagnosis. And again, we use that, plus that's coupled with our echo finding. Our echo finding indicates to us just kind of on a structural level what exactly is going on, and then also what the ejection fraction is for the patient. And those are confirmatory to help, determine if a patient has heart failure. And as you can see, this just highlights like kind of what an echo looks like when done for a patient. So this is like, a computer, it's recording a sound wave and that echoes and displays a picture of the heart. And then, that's pretty much how it's conducted. Okay, any questions so far regarding just confirming the diagnosis of heart failure before we go into the staging and severity and all that? So this is a detailed table that combines both the staging system as well as breaks down like the functional class, which is based on symptoms of heart failure. So staging of heart failure is done from stages A through D. They progressively get worse, as you can see. So A starts off in more of that risk, like there's a high risk, but not exactly at the diagnosed level yet. There's no structural disease present, and they don't really have symptoms. But then as you can see, B, it escalates a little bit. And then when we get to C, so we start to see structural heart disease with prior current symptoms. And then D gets to that advanced stage level. So that's where the patient has symptoms at rest despite maximal medical treatment. And then when we look at the functional class, so the two organizations that have developed these are, there's New York Heart Association, which is NYHA, and then ACC-AHA, which you all are familiar with. They do the heart hypertension guidelines, they do the coronary artery disease guidelines, all that good stuff. And so the functional class, it reflects essentially like the symptoms that the patient has. So that's 1 through 4. And 1 being no limitations, no symptoms really that are impacting the patient's quality of life. And then when we get to stage 4, that's unable to carry on any physical activity. They're basically having symptoms at rest. So as you can see, 1 through 3, our stage C group, this is essentially the group that corresponds to our heart failure with reduced ejection fraction, stage C. Like this is the group that we treat pharmacologically. That's the most common subset that we are treating with medications. Okay, and then these patients, they have symptoms anywhere from 1 through 3. The classes 1 through 3. Any questions about this? It's a lot to take in, so definitely take a second to understand it. But the bottom line with this table is pharmacologically, our focus group would be stage C, and then so stage C, and then we typically look at where their symptoms are. Our treatment group primarily focuses on like class 2 and 3, just because as far as like class 1 goes, they're not really having bothersome symptoms. Their quality of life isn't being affected in the same way that class 2 and 3 is. But at that point, like their symptom control is managed a little bit differently. So that's the key difference. But our focus again is our stage C folks. Yes?
Just to emphasize on what you said. You said stage C group, they are the treatable group that have ejection fraction of less than 40?
Yes. Stage C, heart failure with reduced ejection fraction. That's essentially how this group is identified and how in the guidelines too, and I'll show you guys that. I think it's in the next slide, next lecture series. That's kind of how the guidelines groups them. So stage C, heart failure with reduced ejection fraction. Any other questions? Okay. All right, and then here are some examples, some sort of active learning that we can do. So the assignment is to look at the following patients, and then according to the NYHA functional class, we can group them. So say a patient experiences shortness of breath while they are cooking dinner. Where would you place that according to just looking at this? Cooking dinner. So 1 through 4. Just read the details that are tied from 1 through 4 here. 3. I'm hearing 3. 2. Okay. Any other thoughts? Do we agree, disagree? Does anyone have think 1 or 4? Okay, well, for the sake of time, I will say 2 or 3 is fair. I'm glad that there's a difference in how we view that because sometimes that can happen. This is a little subjective, as you can see, because these activities like slight limitation versus marked limitation, it's viewed a little bit differently. That's where the patient helps us to tell us, this is really affecting my day-to-day because I can't cook dinner and I love cooking dinner. So the fact that I can't, that bothers me, right? That's where we would go according to whether, they're either in the class 2 or class 3 category. So I think that that's fair. Either or, depending on, again, where the patient is and how much that is important to them. How about sitting reading a book? Probably 4, right? Because there's not really much physical activity involved with reading a book, right? Like you're sitting, reading, you're kind of at rest at that point, right? So in that way, because class 4 is for those folks who have symptoms of heart failure at rest, that's probably our classification there. How about running sprints at top speed? Probably 1. Yeah, any of us, or I don't know, for me, okay, I would totally, have a hard time with that. So in that way, that's not necessarily considered ordinary physical activity. So that's why we would probably, group that patient in class 1. Walking 4 blocks.
2?
Yeah, I would say that's a pretty consistent one. Class 2 seems fair. How about walking 10 feet?
3.
Yeah, 3. I think that's a fair one. And then how about the last one? Watching TV. Yep, exactly. So that's at rest. The patient's just chilling, and yep. Okay, so that's something that we commonly evaluate. If not clearly defined for us, then we would just refer back to, again, just kind of what each class entails, and then group our patient according to that. Okay, and then of these statements, which of the following is incorrect, so we'll take a minute to read them. see what you all think. And again, incorrect, not correct. Any thoughts? B. Yeah, so as we discussed, heart failure with reduced ejection fraction and preserved ejection fraction, it's about 50-50. So just to address the other two, heart failure with reduced ejection fraction, that refers to the presence of symptoms with an ejection fraction of 40% or less. So that is true. Now, I know in some cases there's a little bit of variability with this, and I will clarify whether it's less than 40% or inclusive of the 40%, so 40% or less or less than. So I do believe that it is inclusive, so I'll make sure that that's clarified, and I'll probably send out an announcement just to make it very, very clear. And then the New York Heart Association functional class, that may be improved, but the ACC-AHA stages are progressive and may not be reversed. So again, looking back to that slide, as you can see, stages A through D, unfortunately, they do go in more of a progressive way. So it's not necessarily that you can backtrack on that. But when we think about functional class, the great thing is that we have pharmacologic treatment options, ones that help with mortality, so they provide mortality benefit, but then also we have a class of medications that helps with the symptoms. So that targets patients being able to go about their activities of daily living so that they don't have as many limitations and they can live a relatively normal life. So that's something that can be addressed, but unfortunately the staging A through D, as we continue to see the findings of structural heart disease, that continues to get worse due to the course of the disease. So that is that. Okay, so just to summarize everything that we covered, so this is heart failure is a clinical syndrome, results from structural or functional impairment of ventricular filling or ejection. We have two main big categories, but you saw the in between subsets as well. The two big categories are heart failure with reduced ejection fraction, aka systolic dysfunction, and then we have heart failure with preserved ejection fraction, which ties to an impairment of the diastolic function. Compensatory mechanisms are activated to maintain cardiac output, but they can cause secondary damage and lead to disease progression. Some symptoms that we covered were dyspnea, aka difficult labored breathing, fatigue, reduced exercise tolerance, and signs of fluid overload. And then diagnosing heart failure, so no one test does it for us. We look at a combination of things. But the main lab findings that we look at are elevated BNP in combination with looking at the echo findings. And then heart failure disease severity can be classified using the staging system by ACC-AHA and then New York Heart Association functional class. That is that. This sets the tone for the rest of the lecture series to come. That's it. Any questions? All right. We will see you guys next week.
All right, folks, thanks so much for coming today. Appreciate it. Have a great weekend.